Okay, so the new classifications are WHO versus ICC, of course, the molecular IPSS and the new response criteria, the IWG 2023 criteria. So next slide. So that there are indeed, we know, discrepancies between ICC and WHO. And for ICC, one issue I think is this MDS AML category with 10 to 20% blasts. And, you know, it's unclear what is being designed. Is it I'm afraid for some centers it's to increase the number of patients in their trials. It could be also interesting if it allows patients to have, for example, AZA plus VEN with lower blast counts. But I'm I'm not very convinced because when I started hematology, I mean the threshold for MDS AML was 50% blast plus myeloblast plus promyelocytes, and then it became 30% blast plus myeloblast, then 20% blast plus myeloblast, and now 10%. And as I'll show later, I mean the response to chemotherapy in particular is not the same in patients with less than 20% blast. So on the one hand, and that's you have colleagues that say we want to have personalized medicine, and the other hand, it's a kind of one size fits all. So it's really a contradiction. So that's the threshold 10%. The next one, and I'd like to show. So the next slide is the difference for TP53 mutation. And if you take here this example, this is now the WHO classification. No, can we go back one slide? So you see that for patients with a TP53 mutation, no, it's not here. So yes, the multi-hit TP53. So it's having at least more than 10%. So next slide. If you go now to MDS, what you call MDS with biallelic TP53 inactivation, 2 and more TP3 mutation. So and you have the MDS with low blast and isolated Del5Q. We know those patients often have small TP53 clones. So a patient with low risk MDS with Del5Q, no increase in blast with 2 clones, 2 and 3% or 4 and 5%, as it occurs pretty frequently. Sometimes they have even 3 or 4 clones, would be classified easily with MDS with biallelic TP53 inactivation. Although it has nothing to do with the patient with a 3-line karyotype with monoSOVI 17 or 17p deletion, and who has a very poor prognosis, because we know the small TP53 clones can disappear with time. So once again, I mean, it's a kind of mixture which, in my view, has limited clinical relevance in many patients, and mixing those patients. And if you can go to the next one. So, and this is now the definition by WHO, which is already different, because now it's 10% at least, and depending on the blast percentage, the TP3 mutation. Once again, you mix up patients with small clones and patients with bigger clones, because a biallelic mutation can either mean a loss of one allele and one mutation, which is generally seen in patients with complex karyotype, or perhaps Del5Q patients with 2 small clones. So I'm just taking the example of TP53 mutation, but those classifications are so different. No, see, here it's ICC, sorry. And it's the first time we have two classifications. And once again, as I showed in the previous one patient with no excess of blast and isolated Del5Q could be classified in 2 categories with completely different prognosis. So next slide. So I think there are, as I said, discrepancies with reality. I mean, a patient with no excess blast, isolated Del5Q and 2 small TP3 clones, it has nothing to do with the 3-line patient with 3-line monosomal karyotype Del17p and a mutated TP3 greater than 50%. Their prognosis is not the same. And we also know that intensive chemotherapy does not work the same in patients with marrow blast below 20%. overall. I'm not saying some overall. And it reminds me of a former classification where patients with SF3B1 were classified in 3 different groups, and that changed again. So those changes, I mean, are largely made, and I must say, without a real clinical discussion every time. I've participated to some of them, and there was very limited time for discussion. The decision was made, based on, and I'm sorry to say, the problem is for experts, it's okay, but for people who have a relatively limited, who see a limited number of those patients, you could mixed up things very easily, and especially as there are two classifications. So this is, in my view, misleading, and once again a contradiction between the idea of a personalized medicine on the one hand and trying to put everyone in the same trial. And I know some the people who design that want to have there are some countries where MDS with increased BAS have been treated like AML for years. And so, well, that's okay. So next slide. So IPSS now, I like to say IPSS in general. So we'll come to IPSSM. We have to bear in mind that IPSS has been established, all IPSS, classical, revised, molecular, has been established in patients with a median age greater than 70 years, not treated intensively, many of them dying from other causes. And so this may, of course, introduce a bias. Fortunately, we did not take into account age in those in IPSS, because of course younger patients live more than older patients, and even when they have no disease, by the way, and whatever the disease. It does not take into account comorbidities, but that can be added. What is important, in fact, is that in MDS, and we showed that a long time ago, but it's been confirmed, that the loss of years of life is always more important in younger patients. So that's why you taking a score based on patients age greater than 70 is not, especially is not very relevant when it comes to deciding on transplant, because of course a median survival of 6 years may be considered as favorable in older patients, in very old patients, but not in younger ones, obviously. Next slide. So now the IPSSM, now, of course, not all centers have NGS, especially rapidly. I mean, we generally have IDH, NPM1, FLAT3 in 2 days. The rest takes some time. Treatment approvals have been largely based on classical or revised IPSS, so it's a bit difficult to adapt on IPSSM. Outcome may not be corrected by treatment, including allo stem cell transplantation. So the next slide. This is a slide given by Matteo Della Porta with transplant based on IPSSM. As you can see, unfortunately, transplant has no influence on the prognosis of the predictive outcome of IPSSM. So you may, that's the issue, and it's a very unfortunate in the case of MDS. So next slide. I would, however, therefore say that it's still difficult to take therapeutic decisions based on just on mutations. That is the difference between classical or revised IPSS and molecular, with perhaps a few exceptions. And of course, that's the discussion. SF3B1 isolated or with TET2 mutation and no unfavorable mutations. I would tend to say that this means no transplant, except perhaps in very young patients, but those are very rare. So we prefer to say to our patients who are older than 60, well, it's better to be transfused every 2 weeks than taking the risk of transplant. Perhaps that can be a discussion with Theo and others. We reviewed recently the outcome with transplant in our 2 last GFM trials. So it's not like big EBMT or IBMTR studies. Some patients were transplanted 15 or 20 years ago. Those are recent patients transplanted in the last 5 years. Both trials had a median age of 62, and the transplant-related mortality, those were multi-center trials, and the transplant-related mortality was 16% in one, 18% in the other. So transplant is still a risky procedure, even now. So a patient with SF3B1 would, for us, not be a candidate if he or she is older than 60. And I'm not speaking, of course, of the morbidity. High VAF biallelic TP3 mutation, of course, this is very severe. But it's always, almost always predicted by complex karyotype. You know, of course, that's important. And of course, we know those patients tend to relapse post-transplant. So I know some centers even don't transplant them. What we do is to try to transplant them and try to do some preemptive treatment behind after transplant, although we have no idea if this is efficacious. What appears to be important for us is the targetable mutations, and we unfortunately have only few, and I'll show a few slides, which you all know. And NPM1 is, well, FLT3 ITD is rare in MDS, but can occur, of course. IDH1, IDH2 is not so frequent, can occur during progression, and that's why we assess those mutations every 6 months or so, because they can appear. NPM1 mutation is also rare, but it can occur in MDS, and it has been suggested, especially by MD Anderson studies or others, that those patients could respond to chemo or aza plus ven. So certainly those are mutations that can be taken into account. For the other mutations, I must say, I don't like to take a decision of transplant because that's the main decision to take in MDS. I don't like to take a decision of transplant just based on other mutations. Saying that's a patient I would not transplant, I'm seeing mutations, I would transplant the patient. Of course, unless there's progression, there's anemia, thrombocytopenia, excess of blast that do not respond. Otherwise, classical indications. But for me, mutations add to therapeutic decisions only in the case of FF3B1, as I said, TB3, IDH, IDH2, FLT3 ITD, and NPM1, which is, but for the other ones, I must say I'm still quite skeptical if it's just the mutations, and in particular a patient who is not anemic, etc. So I would wait. Next slide. Just those IDH inhibitors. So we presented studies with IDH1 and azacitidine, ivosidenib in 3 cohorts. One high risk MDS resistant to HMAs, one first line treatment, high risks, and one low risk resistant to EPO. Next slide. Just to show you for IDH1 inhibitor that the response rate, especially in cohort B, that is the untreated patient, was 91%. So the other ones were fair, but this one was really impressive. And the next slide, with a median survival in that cohort, which was not achieved. And based on DINARDO and those results, which were incorporated actually, FDA accepted yesterday IDH1 treatment for MDS in addition to AML. So it's really an important mutation, and there can be there can be responses even in patients with low VAF mutation. So I think it's really a crucial mutation for decision making. And there, in this situation, indeed, mutations are very important. The same for IDH2. So next slide. We all know, of course, the combination of azacitidine and IDH1 in AML, and that is probably true also in high-risk MDS. Next slide. And this is the same for azacitidine in patients with IDH2 mutation, which is what is very interesting in this slide, and I will come back to that for the IWG criteria and what should be taken into account as endpoints. As you can see here, there's a difference in event-free survival but no difference in survival between AZA and AZA plus enazidenib. But you can see that the median survival was 22 months in both arms. And actually, this never occurs with azacitidine alone. What happened was that probably almost all patients in the AZA alone arm received enazidenib for second-line treatment. So this stresses the importance of other endpoints than just survival, surrogate endpoints and earlier endpoints like event-free survival. So next slide. And so I'm coming to those criteria. I mean, the idea to change those criteria was made came with Amer Zeidan, who compared one of the GFM trials where we had used either the old IWG 206 criteria for MDS and the AML criteria, and the response, the CR rate was twice as much in using the AML criteria. And one of the reasons was that for CR, to be considered a CR, you needed to have a hemoglobin count greater than 11 grams. And that did not occur so much. So the response rate, the CR rate increased from 25 to 50%. So this is the reason why a group has changed those response rates, and this is here. This is in fact here. It's not the response rate. It's the criteria. The time to event, the endpoints. So overall survival, event-free survival, progression-free survival, which may be surrogate endpoints. And the next one are the response rate indeed. Next one. Yes, CR with, equivalent, etc. Marrow CR is no more taken into account. So I think it's important to evaluate new treatments. Marrow CR was misleading in the absence of hematological improvement and probably gave false responses. So I'm not going to, you've seen this paper, so it may be interesting to evaluate new drugs. So next slide. And so these are the progressive patient, progression, relapse, etc. Next slide. And this is my conclusion. What we need is new drugs, not new classifications. I'm sorry to say that, but yeah. But
Thank
of course,
we of course
need mutations. We need some mutations, definitely. Yeah.
Any questions for Pierre? So
I'm very provocative as usual, Theo.
Yes, that's why we like you. But the discussion on the, let's say that the place of transplantation in relation to the molecular aberrations, and so you discussed, let's say, only the very well-defined smaller groups of the patients with mutation, because the major group has those SF3B1 mutations and TAT2 mutation and FLT3, the TP53 mutations. So it's about 70% of the patients you did not discuss and consider that in your transplant discussion, I suppose.
No, what I considered is that the other mutations I did not take into account for transplant decisions alone. I would say a patient I would not transplant, having the other mutations, it would not change my decision, at least without evolution. That's what I'm saying.
Yeah.
Pierre, I have one question.
Yeah.
So patient without SF3B1 mutation or TP53 mutation, what will you use as a marker for transplant indication?
Well,
Blast count?
No, I would tend to say the revised IPSS or yes, mostly, yeah.
Okay, thank you.
And of course, evolution too, obviously.
Yeah, thank you. I understand.
And by the way, it's not the question here, but we are impressed by the interest of the AZA plus VEN combination before transplant. I mean, of course, we know sometimes we advocated with Theo during many years intensive chemo. It remains true in the absence of unfavorable karyotype. I think azacitidine is pretty disappointing because it does not give a CR, many CR or PR, but our impression with AZA plus ven, we still are not sure it improves survival in those patients, but at least it allows to bridge many of them to transplant generally rapidly. So it's probably a good regimen before transplant, but yeah. I don't know what you think, Theo.
Yes, I do agree, but also in, let's say, according to the IPSS-R, when you so we usually have somewhere in the intermediate group, we have a sub, let's say, a subdivision between less than 4.5 and more than 4.5, because they're but also in the so-called lower risk group, the total group, you have some subgroups which are candidates for transplantation. For instance, patients with a high transfusion burden, which does not respond to interventions, and patients with other adverse, for instance, cytogenetic adverse or molecular adverse factors. So you have to consider that in these patients for transplantation. So these patients might be transplanted without earlier intervention. So these are patients with less than 10% blasts.
No, of course, yes. I was thinking of patients with more than 10% blasts, yes.
Yeah, yeah.